Okay, everyone. I am getting off work as usual and thought I would talk about the treatment of acute mania, as that is something that I often see here on the inpatient unit. So, usually, when somebody gets admitted in a state of acute mania, they are not coming here willingly. Oftentimes, they're either brought in by police or brought in by family, transferred from another hospital. And so the trickiest part in the beginning is just sort of meeting them where they are and trying to get them to agree to treatment. Because most of the time they don't think there's anything wrong with them. Sometimes they do. Sometimes they do have some preserved insight. And those are definitely a lot easier cases when someone kind of is able to assess that they've got something wrong with them and you're able to talk to them about what you think is going on. Other people, not so much. But sometimes you can identify areas where they do feel like something is wrong. So, for example, sometimes my patients admitted with mania, they're totally in disagreement with the idea that they are manic or have bipolar disorder. And I will be very upfront about what I think is going on and why. I'll say, hey, after our conversation today, I think you have bipolar disorder and you're in a state of what we call mania. And it's a mood state where you are having racing thoughts, you've got a lot more energy, there's some disconnection to reality that often happens, a thought disturbance, and I'll just kind of tailor it to what set of symptoms they're actually experiencing. I don't try to hide anything or be guarded in any way. I'm really being forthcoming about what I think is going on. And, they can agree or disagree, right? So let's say that they come in, they're clearly manic and psychotic, but they're not having any insight into that. Usually they will have some complaint about something. So, for example, a lot of patients might say that, no, I'm not manic, but I've got ADHD because I'm just all over the place. I'm very disorganized. And of course, it's not from ADHD, it's from their mania. And so then you can try to work with that. Or they might identify that they're not sleeping well. And you could say, hey, well, again, I think you've got bipolar disorder, but I understand that that's not what you think. But it sounds like you are agreeing that you have a problem with your mind kind of racing all over the place, or um, you've got a sleep issue. So why don't we try to work on that? And here's this medicine. For example, there's a medicine, olanzapine, that I think can really help you sleep. It does also help with bipolar disorder, but why don't you just give it a try? And if it helps you sleep, then great. I think that'll make you feel a whole lot better anyways. And if I'm right and you got bipolar disorder, it'll help with that too. And oftentimes I'm able to work with people on that and be able to find some common ground, even though they're not fully in touch with reality. So that's one approach. And of course, if you and 9 times out of 10 that works. Very, very rarely do I have to go to the courts and get court ordered medications or something like that for mania, because we're able to usually find something to agree on. All right, so that's kind of step one. I should say, just backing up a little bit, that mania, it can sometimes be easy to miss. And so that's where if someone lands on me on an inpatient psychiatric unit, as I tell my patients oftentimes, I have to assume that there's, something going on, because it's not too often that someone just lands on a psychiatric unit for no good reason at all. And so, and I'll tell my patients that. But this is where I mentioned this in another episode. Collateral information is super important because patients can often present well, even when they're floridly manic for a period of time. Even in that your first initial evaluation, they might appear well. There might be something subtle going on, but not enough to where you'd say this person needs to be involuntarily hospitalized. Oftentimes, in my case, in my hands, patients can present well for like 20 minutes and then they totally derail and their psychosis reveals itself as you go on a little bit longer. But you really do need to get collateral, call family, call friends, get get hopefully more than one piece of collateral, right? Because they might present well that first time, but then you talk to their mother or brother or whatever, and they haven't been sleeping for a week and they've been doing all sorts of bizarre things and so on and so forth. And then you might go back to the patient and say, hey, I talked to your mom and she said you were doing X, Y, and Z. And usually the patients don't lie about it. Usually they're like, yeah, because they don't think there's anything necessarily wrong with that in their manic state. So that's just a little bit of the kind of upfront process. In terms of treatment, so I think getting them to sleep well is of utmost importance. So, for example, aripiprazole is a perfectly reasonable anti-manic agent, but it's on its own not going to get them sleeping well in the beginning. All right. So you really either want to choose a sedating antipsychotic like olanzapine or quetiapine, and use that as your anti-manic agent and your sleep aid. Or if you're going to use something like aripiprazole or ziprasidone or some of the others that are not as sedating, then you're going to want to pair that with a sleep aid. And you're going to probably need to use something fairly robust. So I don't hold back when it comes to helping people go to sleep when they're manic and they've been barely sleeping for the past week or so. So I would have a low threshold to go straight to something like Ambien, Zolpidem, or even a straight benzodiazepine, because again, sleeping is really important. You could use diphenhydramine, Benadryl, but usually that's often not enough for true severe mania that you're going to see on the inpatient setting. So yeah, I'm often going towards Zolpidem or one of the other Z drugs. And, the other advantage of that is they're really easy to titrate. For example, Zolpidem basically comes in, if we're talking about the immediate release, basically comes in two doses, 5 or 10 milligrams. So you can get to an effective dose really quickly. If you're trying to mess around with trazodone, someone that's manic, it might work for them, but you might have to ramp all the way up to like 300 milligrams for it to work. Okay, so typically when someone's in acute mania, I'm going to use an antipsychotic, which I think is an outdated term. I prefer the sort of mechanistic term of like a dopamine blocker or dopamine modulator. But anyways, that's an aside. I'm going to use a dopamine modulating agent like the old antipsychotic class, generally going to be a second generation antipsychotic. And I'm generally going to pair that with a mood stabilizer. And typically that's either going to be lithium, valproic acid, or carbamazepine. Now, if I'm using a sedating antipsychotic like olanzapine or quetiapine, and this is a first manic episode, and we're not even quite sure if this is mania. This seems like mania, but the psychosis is more prominent. Then I might just stick with the antipsychotic as monotherapy for the time being, and reconsider adding on mood stabilizer when I'm more sure of what's going on. But if this is very clearly mania, especially if there's mania with psychotic features, which generally there is on an inpatient setting, I'm going to be doing second generation antipsychotic plus a mood stabilizer, and generally one of those three that I just mentioned. So the typical mood stabilizers like carbamazepine, Depakote, lithium, those are more for the long-term course, for long-term mood stabilization. They don't work as fast typically as the antipsychotic agents, especially the sedating antipsychotic agents. Generally, you can get someone out of mania with an antipsychotic and good sleep on its own, but it's the data for long-term use is not as robust as for lithium. The other thing I would say is that when patients are really manic, they've got severe psychosis, severe mania, they're very psychomotor agitated and excited, they can often tolerate very high doses of medications. And that often needs to be tapered down as they get their mania under control. So, for example, I sometimes have to get my lithium levels right up into that 1.0 to 1.2 range when they're super manic. And I might have them on, in addition to that high dose lithium, on max dose quetiapine. We're talking 800 milligrams total. And I might also add them on a separate sleep aid because it's, even 800 milligrams of Seroquel is not enough to get them to sleep. And then after a few days, they're starting to emerge out of the mania. And then they start to, and I should say, even with all those medicines, at first, they're still, fairly slowed down, right? That's how manic they are. But after a few days, the medicines are starting to take effect. They're getting good sleep. They're, they're, they're starting to, the psychosis is resolving. Their psychomotor agitation is resolving. Then they are actually start to experience some of the side effects of those high doses. So I've had cases where, someone was on high dose lithium, high dose quetiapine for like a week straight, no side effects whatsoever. It seemed like it was barely touching them. And then, um, after a week, they were emerging out of their mania, and then they started getting extrapyramidal symptoms, Parkinsonism, and they were starting to get the tremors from the lithium. And this was all new. And I think it's just, when the brain is super revved up and manic, it can just tolerate a lot higher doses than when it's not. And so you have to dial that down. So I had to lower the dose of the lithium, lower the dose of quetiapine. And of course, for the EPS, I'm treating that acutely with an anticholinergic. In that case, I used benstropine, 1 milligram twice a day. And then they were fine. So usually that's the kind of approach that I take for acute mania. And then on the inpatient setting, they're going to be discharged on that combination of a mood stabilizer with a second generation antipsychotic, uh, plus or minus a sleep aid. And, if I were taking over as the outpatient doctor, then, there's so many variables here. So it's hard to give just kind of straight advice here. But this is a very first manic episode, then I'm, probably going to keep them on the antipsychotic for a few months, and then we might taper that down and just leave them on the mood stabilizer for a while. And then it's a conversation about, well, this is a first manic episode. This seems clearly like bipolar disorder. Maybe if there was some provoking factor at play, maybe some substance use, or this is maybe SSRI induced or something like that, you could potentially have a conversation about, do we taper you off medications completely and see what happens versus keeping you on a mood stabilizer indefinitely? And ultimately, that's going to be up to the patient. And you can talk about the pros and cons of that. Of course, if someone's had a history of recurrent severe manic episodes, then at that point, you're really going to be solidly recommending they stay on a mood stabilizer at least. And they may need to be on the combination of a mood stabilizer and antipsychotic for the long term. Because everybody with bipolar disorder is a little bit different. It is a stochastic condition in the sense that the probability of one individual switching into mania or switching into depression can vary quite a bit from person to person with the condition. All right. So that's obviously, there's so much more to say about the diagnosis and management of acute mania, but these are meant to be kind of brief, bite-sized, just little thoughts on things as I drive to and from work. So I am just pulling up into my neighborhood here, so I will have to leave it there. But if anybody has any comments, you can leave a comment on the Substack or email me at Brandon, BRANDON, at BrandonBrownMD.com. And I did change my email, so in some of the earlier episodes, I was giving a different email. I'll still respond to the other email, but I thought it would be easier to use the Brandon at BrandonBrownMD.com email address. All right, take care.